Hi, my name is Khalid Sharif. I'm a consultant orthopedic surgeon with an interest in sports surgery, and today I want to produce a video talking about hip pain in athletes. This is a request by a friend. I'm going to speak about the causes, how to diagnose it, how to treat it, and it's going to be 3 videos because it's an extensive subject. But please, if you do like it, then do give it a thumbs up, subscribe to the channel, and share it. And leave in the comments if you want me to address further sports injuries, and then I will try to add it to the channel. Let's dive in. So when a patient comes to see me with hip pain, I ask them, where is the pain? And if they say it's in here, in the groin, I call this the C sign, and I know it's from their hip. If they say it's in here, I call this the buttock sign. I know it's probably from their back and not from their hip. The first cause I want to talk about is femoral acetabular impingement, and that is a cause very dear to my heart because I did a fellowship at King's College Hospital on this. It's when the ball of the femur catches or impinges on the socket due to either an osseous bump on the femur or a pincer lesion on the socket. And the way to diagnose this is through what's called a Fader test, when you bend the hip, flex it, adduct it, and internally rotate. And if that produces the pain, then it suggests that it's femoral acetabular impingement. And you confirm the diagnosis with an X-ray and then finally with an MRI scan. The majority of these settle down with conservative treatment of activity modification, physiotherapy, non-steroidal anti-inflammatory, sometimes an injection. But if it persists and it can cause a labral tear, which is a tear in the cartilage of the hip, then it will need an arthroscopy, keyhole surgery, to do either a femoroplasty to address the bump on the femur, or acetabuloplasty to address the pincer lesion. The second cause is osteoarthritis, and although this is rare in athletes, but it can happen at the end of their career, or if they've had a severe injury, then they will get pain deep in the hip, and it's felt in the morning when they get up, but it's increased with activity, and then when it's very severe, it even stops them from sleeping at night, and it can be associated with crepitus. And here I flex the hip and internally, externally rotate it. And if that reproduces the pain, sometimes with crepitus, it suggests osteoarthritis. I'll get an X-ray, and this will show, it may, in the early stages, may show nothing, but in the later stages, it will show narrowing of the joint line, sclerosis, osteophytes. The majority, especially the mild ones, will respond to conservative treatment. As I mentioned before, sometimes an injection of steroid, but if it is more severe, then it will need a hip replacement. The third diagnosis is pain with a pop, what I call a popping hip, a popping painful hip in an athlete. And this is an extensive diagnosis, not one diagnosis, and I want to address it in a separate video, so look out for that. The fourth diagnosis is adductor injury, and that is usually an injury to the adductor as it attaches to the pubis, the adductor magnus. That is persistent in one place, always there at the same place, usually after an acute injury, and it's associated with local tenderness in the same area. And the way I test for that is you flex the hip and adduct, you put the adductor under tension, feel the tendon, and if they feel pain, it suggests this, but I augment it with resisted adduction, and if that increases the pain, then it suggests it's an adductor injury, and I get an ultrasound or an MRI, and the majority of these respond to conservative treatment. The fourth diagnosis, or the fifth diagnosis, is apophysial injury. That usually happens in younger athletes, 10 to 13 years of age, and I've seen them come off the track after usually jumping or hurdling. They'll feel pain deep nearer the pubis where the adductor attaches to the pubic bone. Instead of the tendon rupturing or straining, it usually pulls on the growing part of the bone, and these inevitably, all of them settle down on conservative treatment. You may give them a crutch and for a while and give them rest, and later on physiotherapy, and they all come back to their activities, athletic activities later on. The other diagnosis is Ostitis Pubis, and this is involving the symphysis pubis here in the middle, but it can radiate to the area of the hip, to the groin, but it's always persistent there. It's associated with local tenderness there, and you can get an MRI scan and you will diagnose this, and all of these will settle down on conservative treatment. Hardly ever had to operate on these. The final diagnosis is a sports hernia, and this is an extensive diagnosis, and I think there's a lot of confusion on whether or not it's a hernia and how does it differ, and therefore I've decided to address it in a separate video, so look out for that. I hope this is helpful. Thank you very much.